Man, getting old sucks. Spent the weekend moving furniture, and I feel it in every myocyte in my body. But you don't care. You're here to hear about infectious diseases. This is the Puscast, covering the first 2 weeks of August 2013. I continue in my tradition of podcasting outside because it's summertime and the living is easy. Don't forget, this is brought to you by Pusware LLC, publisher of the Infectious Disease Compendium, a Persiflager's Guide. Find it online and the rest of my growing multimedia empire over at moremark.squarespace.com. References are online. I have nothing else to say except to get on with the literature. And there'll be occasional cars going by and dogs barking, and you're going to have to live with it. Because I don't want to sit inside on such a gorgeous Sunday afternoon. Besides, it hurts too much to walk up the steps. A continuing problem when you're 392 in dog years. Woof. The last SARS virus, the one from about a decade ago, probably came from bats out of China. How about the current one, where there's some evidence currently that single-humped camels are at least infected with the SARS virus found throughout the Midwest. They looked for seropositivity in animals and found that 50 out of 50, 100% of Omani camels were positive for past infection with the new Mideast coronavirus. There's also been some suggestions, evidently, that it also is related to a bat coronavirus, and perhaps it went from bats to camels to people, or from bats to people to camels, or maybe from bats and then simultaneously to camels and people. But it would appear there's some exposure to camels, and the camel milk, for example, may play a part in the spread of this new coronavirus. And here I thought it was spread by weak Mexican beer. And now I got that damn song stuck in my head. My Corona. Weird Al, I'm not. So there was a study that suggests that CMV infection is associated with Alzheimer's disease. This was in clinical infectious diseases. What they did is they went back and got a bunch of specimens that were frozen from the serum, CSF, and lymphocytes in patients in an Alzheimer's disease center, and found that those who had CMV were more likely to have Alzheimer's. And they found that the CMV was able to induce in the test tube beta amyloid. So this is a new association. Again, association is not causation, but is an interesting, perhaps, cofactor in the development of Alzheimer's. As I've said many times, and I stole this from Dr. David Gilbert, infections only have three etiologies. They're genetic, they're wear and tear, and they're infectious. Hepatitis C medications are multiplying faster than HIV medication these days, and they're trying to get on to therapies that don't require interferon, which is quite a toxic medication, all things considered. This was in the New England Journal of Medicine, and they've come up with two new drugs I'm probably going to mispronounce. Feldeprevir, which is a protease inhibitor, and Deleobuvir, Deleobuvir, which is a non-nucleoside polymerase inhibitor. And when they combine these two drugs with ribavirin, they got a pretty good outcome for the treatment of chronic hepatitis C. They had a sustained virologic response in about 52 to 69% of patients, which is pretty good considering you don't have to give a more toxic agent like interferon. One of the endlessly entertaining and interesting aspects of infectious diseases is transmissions. And no, not how your car shifts gears. We talked about one-hump camels as a source for coronavirus earlier. There was an unfortunate non-Hodgkin's lymphoma patient who acquired fatal West Nile, presumptively from a transmission related to a blood transfusion. And I don't tend to think of blood as a source for West Nile, but patients can get large amounts of blood, and occasionally bacteria or other organisms sneak through. The other was a patient who presented with genital ulceration, and they grew out Corynebacterium diphtheria, and it was a diphtheria toxin-producing strain. That's why the patient had genital ulcers. He got it by way of oral sex with another male. Interestingly, after cure, he refused vaccination. Ugh. Although, who knows, with active disease, maybe he got a nice immune response from getting cutaneous diphtheria in a unique way. In the United States, Lyme is mostly Borrelia burgdorferi. Europeans have at least 3 spirochetes that can cause Lyme-like syndromes. And this study looked at whether or not patients with ECM and neurologic symptoms actually had neurologic Lyme involvement. The answer was most of the time no. Emphasis on most of the time. Those who had a spinal tap that was positive for pleocytosis were actually more likely to have Lyme disease involvement of the CNS, especially if they also had a radiculopathy as part of their symptoms. And most often they had Borrelia garinii, Garinii. I never have heard that organism pronounced, so I think that's correct. And they also tended to have big ECM lesions compared to those who didn't. So occasionally patients who get Borrelia in Europe will get early Lyme involvement with the spirochete. I'm not too surprised with that. Once the organism gets into the blood, there's no reason it can't go to the brain as well. And syphilis has been shown to involve the CNS earlier rather than later in the disease, as demonstrated by culture. I think it's important to emphasize for U.S. listeners, who I presume are the major listeners to this podcast, but I actually don't know, that this does not apply to Borrelia burgdorferi, the cause of Lyme in the United States. Speaking of syphilis, there was a study out of Baltimore in the United States that looked at syphilis acquisition in men who have sex with men. The interesting thing about this particular study is that syphilis is going up, as it is all over the place, but that 1 in 5 men who have sex with men who were diagnosed with syphilis had a repeat infection, most of which were acquired 12 months apart from their first diagnosis. I have noticed that the behaviors that lead to sexually transmitted diseases tend to be repeated. Also of note, it was more likely in people who had HIV disease. So if you're getting syphilis over and over again and you're HIV positive, there's probably two-way transmission of various infections going on, and this would represent a population at increased need for education about safer sex. If you have a bunch of good studies and you do a systematic review or meta-analysis, you can come up with some valid information. It seems that most of the time these days people take a bunch of crappy studies, pull them together, and come up with the conclusion that, hey, look, we have a bunch of bad studies. I guess we need some good ones to know what to really do. This was a meta-analysis that looked at linezolid versus daptomycin in the treatment of VRE bloodstream infections, and came to the conclusion that they look about the same, but the data all suck, so we need randomized trials. Thank you for telling me what I didn't already know. I mean, I don't want to be too snitty. Oh, yes, I do. But really, what's the point of doing a meta-analysis on crappy studies? In the end, it's like Shakespeare said, all sound and fury signifying nothing. I'm not a big fan of contact isolation, mostly because I don't look good in yellow, but also because patients in isolation don't get as good a care as people who are not in isolation. I recognize its utility, and I recognize its need, but that doesn't mean you have to like it. But how long after someone has VRE are they a carrier of VRE? This study looked at 345 patients who had been found to have VRE in the stool in the past, and managed to finagle a whopping 103 of them to submit specimens. They found 13 had VRE. And I'm not certain, given the number of people who participated, that you can say that this information is truly valid. But they found that nobody who had VRE more than 4 years ago was a current carrier. So maybe distant history of VRE doesn't require contact isolation anymore. It wouldn't surprise me if VRE would not be able to survive in an antibiotic-free milieu, since usually antibiotic-resistant strains are at a disadvantage. And not unsurprisingly, having been exposed to antibiotics was a risk for continued carriage of VRE, the human colon, as Galapagos Islands. So does empiric therapy mess up your C. difficile toxin assay? The answer is, oh yeah, sure, you betcha. They looked at the cumulative number of patients converting from positive to negative PCR. 14% at day 1, 35% at day 2, and a whopping 45% of patients at day 3 converted their PCR to negative on empiric treatment for C. difficile. And it didn't matter if they were on metronidazole, vancomycin, or, as some people tend to do, both of the drugs at once. But that's a significant number of patients at day 1 who've converted their C. difficile assay to negative on treatment. So it behooves us, I like the word behoove, it behooves us to order the assay before we start therapy, if at all possible, to confirm the diagnosis. And you're talking to an ID doctor here. Well, actually, there's an ID doctor talking to you. I loathe empiric treatment. I like the old Russian proverb, treat but diagnose. And a nice little bit of curious basic science. Now, you know that Bacteroides species and Bifidobacterium are important in resistance to C. difficile. Great. And obese patients have a different microbiology than do non-obese patients. They have more firmicutes, or maybe it's firmicutes. Must be firmicutes. Firmicutes sounds like a workout joint. Anyway, the obese have more firmicutes and less Bacteroides than do non-obese patients. So would obese patients, because of their altered microbiota, be at increased risk for Clostridium difficile infection? And the answer would appear to be, oh yeah, sure, you betcha. The study was a case control trial that looked at the risk of developing C. difficile and found that being obese was indeed a risk for developing C. difficile diarrhea. Does one good study trump multiple other small studies? I don't know. Maybe, maybe not. A good negative study probably trumps prior positive studies if it is considering an intervention that is fundamentally worthless, like echinacea or acupuncture. Probiotics, I'm not so certain. There's a big study published in The Lancet. What do you do to a boil? You lance it. The study used probiotics to prevent both antibiotic-associated and C. difficile diarrhea. There are over 1,400 patients in both the placebo and in the treatment arm. That's a lot of patients. And they got either placebo or lactobacillus and bifidobacterium. And they found no difference in antibiotic-associated diarrhea and no difference in C. difficile diarrhea, although 0.8% of patients got C. diff in the probiotic group and 1.2 got C. diff in the placebo group. So does this trump the prior recent large meta-analysis that suggested benefit from probiotics? I'm still kind of a preponderance of data kind of guy, as suggested in a recent JAMA editorial, and I still think the preponderance of data suggests benefit from probiotics in the prevention of antibiotic-associated diarrhea and probably to a lesser extent C. difficile. Though I have to admit I'm a wee bit less enthusiastic now than I was before based upon this particular study. And they had remarkably little antibiotic-associated diarrhea overall, a little under 11% in both groups. A much lower attack rate than found in prior studies. I guess they weren't being given augmentin. You think of salmonella, you think of eggs and chickens, but it turns out that different salmonella species are associated with different risks from different foods. For example, serotypes Inaridides, Heidelberg, and Hadar. Wasn't that from Harry Potter? No. Game of Thrones were due to eggs or poultry. But the serotypes Jevania, Litchfield, Mabadka, Munchen, Punen, and Seftenberg usually were associated with plants. And Typhimurium and Newport were associated with a hodgepodge of food types. So different salmonella are associated with different foods. And you can't just say, it was the chicken that gave you the salmonella. And you've heard reports on this of salmonella coming from dog food and dog chews and tomatoes and sandboxes and all sorts of other sources. And then depressingly, there was an outbreak of Campylobacter that was traced to liver pate. I love liver pate. Hey, Bryce, be careful on that treadmill. If you laugh, you may trip and fall. So we're getting closer and closer to a little bit of Koch's postulates. I talked a couple podcasts ago about how they discovered the Pandora virus, which is the new biggest virus of all time. And prior to that, there had been a virus called the Mimi virus that had been seen in patients with pneumonia. It's now been isolated from someone with pneumonia, an elderly woman who presented with pneumonia, and they grew the Mimi virus out by growing it up in an acanthamoeba. Most of these mongo viruses require amoebas to grow in. Now all we need is for someone to pull a Barry Marshall and infect themselves with some Mimi virus to complete Koch's postulates and prove that it is indeed a cause of human disease. Volunteers, anyone? Being deficient in vitamin D, or in some cases having polymorphisms in the vitamin D receptor that decrease its efficacy, is associated with a variety of infections, predominantly viral respiratory tract infections and tuberculosis. So it is important to be replete in your vitamin D. But is being a vitamin D consumer necessarily protective for the prevention of, say, community-acquired pneumonia? There are a lot of people who are on vitamin D for other reasons. But the question is, if you take vitamin D on a regular basis, are you at decreased risk for pneumonia? And this looked at 3 independent case control studies published in the journal Thorax. I think the Thorax speaks for the trees. Anyway, in the journal Thorax, and found that vitamin D supplementation did not decrease the risk of pneumonia. So using it as a preventative medication, although it wasn't being used specifically for infection prevention, is not associated with a decreased risk for bacterial pneumonia. But that's different, I think, than being deficient in the vitamin and getting therapeutic on it. So follow along closely with me here. Patients get stem cell transplants, okay? They get allogeneic hematopoietic stem cell transplantation, HSCT, using umbilical cords. And these patients evidently get a unique form of colitis that is responsive to antibiotics and has a specific histopathology. They have chronic active colitis and epithelioid granulomas. So they took these patients and did magic, i.e., shotgun DNA sequencing looking for a potential organism, and they did find one called Bradyrhizobium enterica as a cause of cord colitis syndrome. So patients who get an umbilical cord hematopoietic stem cell transplantation get a colitis due to that organism. Although what I cannot tell from the article is whether or not they get this infection from the environment and they're set up as a consequence of getting the stem cell transplantation, or do they actually think that the stem cells are the source of the infection? Still, molecular techniques are a great way to look for infectious diseases that cannot be cultured. I send mine up to the University of Washington Immunodiagnostic Laboratory. They don't take insurance, they just take information from the doctor and bill the doctor directly. So I've gotten yet another letter threatening me with collections if I don't pay up, because when you can't bill the insurance, it tends to slow things down. So a warning, if you're on the West Coast and want to send things to UW, put somebody else's name on it rather than yours. That way they can be sent to collections instead of you. Cryptococcus gattii is harder to treat than neoformans, and no one knows what the optimal therapy is. This study out of New Zealand and Australia looked retrospectively at the patients who had either pulmonary Cryptococcus gattii or meningitis, and found that both populations did better when they got induction with amphotericin plus 5-flucytosine. They suggested that for meningitis they should get it for 6 weeks up front, and that for pneumonia they should get it for 2 weeks up front to get optimal outcomes with this particular fungus. It has been a son of a gun to treat, as we have it here in the Great Pacific Northwest as well. And I don't find that unreasonable from my experience, although we all know the 3 most dangerous words in medicine are, in my experience. Of course, given all the biases that are present in retrospective trials, it's hard to know for sure whether or not patients need that up front. But my bias is that patients with cryptococcal disease are best served with amphotericin B and 5-flucytosine first, and then give consideration to azoles later. And we're getting close to the end. I would like to draw attention to an article of general interest. It's called Clinical Reasoning for the Infectious Disease Specialist, a primer to recognize cognitive bias. I have a great interest in this particular area, mostly because all my work over at Science-Based Medicine. This focuses on diagnostic biases that prevent you from getting the correct diagnosis or have you make errors in making the correct diagnosis. The classic cognitive bias article, to my mind, was Spiraling Empiricism from about 25 years ago in the American Journal of Medicine. If you have not read that, you need to read Spiraling Empiricism, and you need to read Clinical Reasoning for the Infectious Disease Specialist, and then followed up with why most medical literature is wrong. If you can read those 3 articles, apply them to yourself in your own reading and clinical practice, you will be a vastly superior thinking physician. Almost on par with me. Whew, boy, there's a wee bit of arrogance, huh? So, that brings us to the end of another Puscast. The references are available online. My growing multimedia empire can be found at edgydoc.com, where you'll find links to my podcasts and my books and my blogs and my apps and, God, just lions and tigers and bears, oh my. And of course, you need to go online and write me glowing reviews over on iTunes about how wonderful you find this particular podcast. And until then, as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation. Goodbye.